So good morning, good afternoon, everyone. Welcome to today's ICAP Grand Rounds webinar. My name is Fatima Churis, and I'm with the Human Resources for Health Development and Training Unit at ICAP headquarters. And it's a real pleasure to co-host this session on vaccine hesitancy. Just a few housekeeping before we get started. We will be using the Q&A box for questions to the speakers. So please feel free to type your questions into the Q&A box at any point during the presentation, but we will only answer your questions at the end. If you can also indicate your name and affiliation or country that you are joining us from into the chat box, that will be really appreciated. We like to keep a track of who's joining us from around the globe. Also to note that the webinar recording and the slides will be posted on the ICAP website, and the link is featured on the slide, as you can see. To give you just a quick overview of today's session, I will be introducing Dr. Jessica Justman, who will be serving as our moderator today. And then we'll hand it over to Dr. Heidi Larson, who will present the state of vaccine confidence in the time of COVID-19. And then we'll get the perspective from Dr. Phionah Atuhebewe, who represents the World Health Organization, and she'll speak to us on barriers and drivers to vaccine uptake on the African continent. And then we will open it up for a question and answer and discussion. So it's my pleasure to introduce our moderator today, Dr. Jessica Justman. She is the Senior Technical Director at ICAP and is an Associate Professor of Medicine and Epidemiology at Columbia University's Mailman School of Public Health. Dr. Justman oversees evaluations, clinical laboratory, strategic information, and health system strengthening programs at ICAP. Her research interests focus on HIV prevention, clinical trials, as well as combination HIV prevention studies. She has extensive experience in conducting population-based studies of HIV incidence in both Africa and the United States. And it's our pleasure to have her host today. Thanks, Jessica. Over to you.
Great, thank you so much. Good morning and good afternoon, everybody. So we have a really great lineup here, and I will introduce our first speaker, Dr. Heidi Larson, who's an anthropologist and director of the Vaccine Confidence Project, a research group at the London School of Hygiene and Tropical Medicine, where she's professor of anthropology, risk and decision science in the Department of Infectious Disease Epidemiology. She also holds appointments at the University of Washington in Seattle, the University of Antwerp in Belgium, and the National University of Singapore. Dr. Larson previously headed the Global Immunization Communication at UNICEF, and she chaired the advocacy task force at Gavi, the Vaccine Alliance, and served on WHO's Strategic Advisory Group of experts in the Working Group on Vaccine Hesitancy. Her research focuses on the analysis of social and political factors that can affect uptake of health interventions. And her particular interest is on risk and rumor management from clinical trials to delivery and building public trust. So I think we'll all agree that Dr. Larson is really absolutely very, very well positioned to speak to us this morning about vaccine confidence. Dr. Larson.
Thank you, and happy to be here today. Let me just share my screen. Here we go. Okay, I'm, as you heard, going to talk about vaccine confidence in a time of COVID. I think it's on everybody's mind these days, or at least many people's. Let me see. But I'll just say a couple words about the Vaccine Confidence Project, which I founded about 11 years ago now, just to try to start to give some metrics and get a handle on the growing amount of what I saw as emerging issues in vaccine confidence in different ways in different parts of the world. But we didn't really have any kind of metric that could compare it globally or also change over time. So we've been doing that for 11 years. In 2015, we established our Vaccine Confidence Index and have been running survey work, again, globally, not just generally, but about specific vaccines. And we've taken that focus to COVID since last spring. And in addition to that, we do a lot of social media analytics, and increasingly, especially over the last 2-3 years, as well as the usual when we could do face-to-face focus groups and key informant interviews. In a few months ago, we published in the Lancet a pretty big paper looking back over the last 5 years, 4 to 5 years. We had these maps are 2015 to 2018, but the paper also discusses a number of settings where we had up to 2019. But this is with the Vaccine Confidence Index from the baseline in 2015. And the left hand is 2015 and the right hand maps are 2018. We have 4 domains of confidence we examine, and they are: vaccines are important, vaccines are effective, vaccines are safe, and vaccines are compatible with my religious beliefs. And it's on a strongly agree to strongly disagree spectrum. Why this matters now, we have really seen that this background vaccine confidence mapping has been really valuable to COVID, because it already lets us know where there is lower confidence in vaccines in general and where there's higher confidence, and to help know where we might need more work for preparedness. As you can see, the good news is that confidence in the importance of vaccines has certainly gone up. The dark blue is the most confident, the dark red is the least confident. But when you start to get into questions of effectiveness, and I'll show you the next map, which is safety, it's a much more varied and fractured environment. So when you ask someone if they think vaccines are important, you're generally going to get, of course, yeah, they're great. But when you say, do you think they're safe, or do you think a particular one is safe or effective, it starts to be much more fractured. As you can see below, that the dark red has faded quite a bit, except for France, which is persisting as being, the number one winner of the most skepticism in the world when it comes to vaccines. Although I have to say they have put a lot of effort into changing to building more confidence, and it is coming up a bit in the confidence index, but still low. But as you can see in Africa, it's starting to change, unfortunately, a bit more to the more losing confidence a bit. That's particularly, this is the safety map. You can see that the confidence has dropped, particularly in Francophone Africa. And and that's for a mix of reasons that we're looking into, but part of it too is we see this in different ways around the world, where language diasporas also are sentiment diasporas. So there's a lot of pretty skeptical Francophone media, that some of which we think is part of the influence here, but there are other geopolitical conflict and different kind of tensions, and just to sheer access to more misinformation. So just an example of how this background of monitoring confidence gives us a bit of a landscape. We shift to COVID vaccines, and we've been doing a lot of listening with Africa CDC. We've just finished a pretty big 15 country study on sentiments and around confidence around COVID vaccine, and are about to roll out another big study with healthcare professionals. But this is across the 15 countries where we surveyed about 17, 18,000, but no, it's more like 17,000 people. There were quite a bit of rumors circulating, which could contribute to what you saw in the previous map. About COVID planned by a foreign actor. It's interesting. Some countries think it's China. Other countries thinks it's U.S. It clearly reflects the dynamics, the political dynamics. But it's not a small number that believe in some of these rumors on the left. Or I shouldn't. Some of them are rumors. Some of them I think are more genuine perceptions and anxieties. But the point I wanted to make here is that among all the 15 countries, Tunisia came up, and the northern region, where you just saw in the previous map, were the most likely to believe in rumors. And these indeed were also in the more general vaccine confidence mapping. We saw that trend there. So that background mapping is being helpful in understanding where this is a uniquely COVID issue or is on the heels of underlying vaccine concerns. Back in June, July, we did a survey with 17 countries, and DRC, which this has come up in a number of other people's surveys too, came out as being more skeptical than France when it came to COVID vaccine. We've actually been doing a lot of work there in the last 5 years around Ebola vaccination. And actually, that has, in the end, uptake has been pretty good. It's been difficult in some of the more conflict areas. But now our concern is that some of the communities might be thinking that the Ebola vaccination, which is continuing, especially as we now have Ebola outbreaks. DRC, it keeps coming on and off, but in Guinea, that we can't lose the plot on Ebola while we focus on COVID. But there are concerns that people will mix them up and not take the Ebola vaccine because they think it's COVID. So there's a lot of managing multiple issues. The most recent global survey we've done is in December, and this is 32 countries. Oops, I didn't mean to have this here, but that's okay. For those, oh yeah, now I know why I put it there. In the USA, a lot of people, there is a lot of misinformation there, but what I wanted to point out here is that it's not at an extreme end when you look at the rest of the world. There are countries that are much more positive and countries that are more negative. In this confidence measure, Lebanon came and Pakistan came up. Lebanon wasn't in the earlier one. We have different mixes at different times. But as you can see, there are no two countries that are exactly the same. And I think the biggest point here is how incredibly varied it is. And that reflects the fact that while there are themes around the world in issues around misinformation or distrust or anxiety about the newness of the vaccine, even, each country and setting has its own character and certainly variability. And even within particularly some of the larger countries, there's even more variability. On the right-hand side, in addition to these basic questions, we always gather all the background socioeconomic demographic data. And in addition, for our COVID survey work, we've been asking about general health, stress, mental health, and how they think the government is handling the pandemic. And we see that the strongest correlate of willingness to take a vaccine is feeling that the government is handling the COVID response well. So it's really quite striking. I mean, we often see how trust, is such a key lever of confidence in vaccines more broadly. And I often say that we don't have a misinformation problem as much as we have a relationship problem. If there's trust there, people put up with a little risk because they trust you that the benefit is worth it. If they don't trust you, they're always looking for something that could be wrong. So trust is crucial when we can't separate misinformation debunking from the environment that the trust context that it's in. In 2018, there were a lot of discussions in the few years before COVID was announced, reported, about the fact that we were going to be having another pandemic. We didn't know when, but the world was aware, or at least the global health community, that we would have another pandemic. And there were a number of roundtables and discussions, particularly after H1N1 was announced as a pandemic and didn't become as big as we thought, but it did stimulate a lot of discussions and preparedness thinking. And Nature asked me to write a commentary, and my view was among the various things that we need to prepare for is viral misinformation. And indeed, I anticipated it, but I didn't realize how much of a risk it would be as it is today. And it's not just about kind of, either remote or uninformed people. I mean, the kind of misinformation, this is in London, COVID is a hoax. And we've got lockdowns in different parts of the world, anti-lockdown, which is also because they think it's overstated. This is in Manchester and in some of the poorest countries. And in some cases, it's an issue of libertarianism, but in others, it's really an issue of survival. There's also things that, are sentiments from the 1800s. In the 1800s with the smallpox vaccine, we have in our archives at the London School and Wellcome Trust, we've got graphic images of people turning into cows because of the smallpox vaccine coming from cowpox, and vaca comes from, and vaccine comes from the word cow. But here, because of the Oxford vaccine having some chimp adeno there, they had a similar image. And when I saw that, I just couldn't help but think 200 years later, we're still have that same kind of imagery in the rumors. A lot of people ask me, does this misinformation really have an impact, a behavioral impact? Is it just misinformation? How much should we be worried about it? We did to address that, so I had a more evidence-based answer. My group did a control trial with 8,000 people, 4,000 in the US, 4,000 in the UK, nationally representative samples. And we gave 1,000 in each country, factual, evidence-based, to the extent that we had it, facts about the COVID vaccines. And for 3,000 in each country, we showed them 5 of the most frequently circulating pieces of misinformation. Before, we asked them about COVID and would they take a vaccine. UK, 54% said they definitely would. 41% said they definitely would in the US. If you add probably would, that would go up, but we use the definitely as a start, as a baseline. And after exposure to the misinformation, there was a 6.4% point drop in the UK in terms of willingness to take a COVID vaccine, and 2.4% drop in the US. But again, the starting point was lower because after the exposure, we again asked a number of COVID questions within which we asked, again, would you take a COVID vaccine? So these things do matter. They particularly matter when already your acceptance is wobbling below herd immunity levels needed. So even a few points when you knock it down, I mean, I think about misinformation as being a tipping point phenomena. It doesn't need to be the majority of people. It's just that extra bit that can really have an impact. What was interesting to us in the pieces of misinformation that we did show people, the thing that the image that had the most impact was the one that looked the most sciencey, this on the lower left-hand corner, the RNA, DNA. And the message that was in this misinformation was that, you know, first they push genetically modified organisms in our food, and now they're turning us into GMH, genetically modified humans. That has gotten much more traction. So I think we shouldn't be quick to say they're anti-vaccine because they do bring science in there as a convincing mechanism. It's just the conclusion and the interpretation is different, and in this case, quite seriously incorrect. Coming back to the Africa study, what was fascinating to me in the and partly not surprising, but I'll keep my eyes open and never assume that I know. A lot of the rumors and reasons for not taking a COVID vaccine in Africa were the same ones that we're hearing in the US and Europe. I don't trust the COVID vaccine. I don't believe the virus exists. I'm concerned about the safety. I don't feel I'm at risk. And I don't have enough information. I mean, these are not unreasonable concerns. And then there were others, you know, as we saw earlier, some more serious ones. But if we don't know what these questions are, and these are the kinds of things that should help inform our communications and engagement. This is my new book, Stuck, which I ironically had just finished just before COVID hit. Although it's turned out to be very relevant to COVID, I managed to get a prologue in just as it went to the press to say how this is relevant to COVID. But anyway, it has some histories and stories that might be of interest and relevance to COVID. And this is our website. If anyone, there's a lot of different resources there for those who would like it. Thank you.
Great, that was really terrific, Heidi, and I think we'll have some very interesting points for discussion after our next speaker. Our next speaker is Dr. Phionah Atuhebewe, and Dr. Atuhebewe is a vaccinologist and immunization expert, as well as a sexual and reproductive health specialist with extensive experience in international project management in the public health sector. She's currently the new vaccines introduction medical officer with the World Health Organization Regional Office for Africa in Brazzaville, Congo. And she coordinates WHO's work in the Africa region to introduce new vaccines and increase uptake of underutilized vaccines. Dr. Atuhebewe is currently coordinating the WHO Africa COVID-19 Vaccine Readiness and Equitable Delivery Task Force. She previously worked with PATH, supporting new vaccine introductions in Africa and Southeast Asia. And she holds degrees in medicine and surgery, international public health, and has training in vaccinology and project leadership and management as well. So I think, as with our prior speaker, we have somebody who is, you know, tremendous expert on the topic. And we're going to hear about vaccine rollout in the Africa region and approaches to supporting vaccine rollout activities. Phionah.
Thank you very much, Jessica, and good day, everybody. So Heidi has given us a very good start to vaccine hesitancy, and my job is simply to give you the experience in the African setting and how this is going on with the COVID vaccine. So throughout the past few decades, the world has seen tremendous gains and progress in ensuring that people access life-saving vaccines. But we've still seen that even with all these gains, as much as they've been impressive, we still have about 20 million children across the world that have not received even their first dose of vaccine. So, and most of these, as we know, are in Africa. And COVID is now sobering proof of how in today's highly interconnected world, disease outbreaks anywhere are a threat to people everywhere. It doesn't matter where you are. So why do these gaps really exist, and what influences vaccination uptake? So working with the WHO expert group, both based on the scientific evidence, we've seen a lot of evidence from Heidi, we have developed a simplified model to represent the drivers of vaccination. And the things that feed into vaccine uptake are what people think and feel, the misinformation that people get, the attitude towards the safety of vaccines and the effectiveness of vaccines. For the first time globally, people have been exposed to science, to a disease as it starts, and then as we try to manage the disease, which happened to be a pandemic and comes with extreme measures as lockdowns. So it is a disease that everybody, even children, even the elderly, everyone took interest in, and it was everywhere. So what now they believe, because it all depends on the information that these people get about something like this. And now we have had people all become virologists, everyone is a scientist, everyone is now a vaccinologist, everyone seems to have an opinion when it comes to these vaccines. So depending on the information they get, that also determines if they will take the vaccine or not. Then we have the social processes, and these are very major in the African context. What do your friends and family believe? What are your workplace norms? Trust in the providers. Heidi mentioned the trust in the governments. And we've seen that generally in Africa, it is about if people trust the government that is leading them. It's not about the vaccine. Because it's being given by the government, then that is a problem, if they don't trust in the government. That is why we've seen in the few countries in Africa, we've only had rollout in 7 countries out of 54 countries. So we can see how unequitable and unfair this has been, but we are looking forward to vaccinating very soon. So out of the 7, we've had most of the first vaccinees being the heads of state and senior level politicians, because this makes such a huge difference. They say if the president can take it, but of course we shall always have they got the Pfizer vaccine and then they're bringing us this other different vaccine. No, we've also seen in places like Cameroon, towards the end of last year, Cameroon was launching an HPV vaccine introduction. We were having a polio campaign with the circulating polio viruses, derived polio. So this polio is a vaccine that everyone in Africa knows. But the population said no, because they said this is a COVID vaccine being tried on us. Now, every vaccine, this is first of all now the most difficult time to introduce any new vaccine. We have planned to introduce the HPV vaccine in a number of countries, the typhoid vaccine in a number of countries, but because of the period we are operating in, any new vaccine is now the COVID vaccine, and it's being tried in Africa. So we had heads of state, for example, the Tanzanian president stand up and say, do not take the vaccine. So such social and highly people who are of high opinion and regarding society can make a difference on if the person takes the vaccine or doesn't take the vaccine. Then while we thought we were still dealing with all this, then comes the variant first identified in South Africa, Then South Africa, which had already procured the AstraZeneca, says they're not going to use the vaccine, and this turns out everything. Even people who still had a plan to take the vaccine, it changes. So we have a lot of work that we have to do when it comes to this. So these factors really do influence the motivations or intentions to vaccinate, or hesitancy around that intention. So this is where we then locate and situate hesitancy. But there are the practical issues. Is it easy and convenient for people to have the vaccines when they need them? We've started with a vaccine that is already, for us in our region, global shortage. We do not have the vaccine for starters. The rest of the world is vaccinating, Africa is not vaccinating. So we already have the supply issue, and somebody will ask, is it worth it? Why would I even bother? They are talking of health workers, they're talking of the elderly, they're talking of people with comorbidities. I'm not any of these. I don't know anybody in Africa. You must know somebody who knows somebody who knows somebody to connect you to something, to a commodity. So if you know nobody, then you don't even bother to learn, to understand about the disease, to understand about the vaccine and issues like that. So such issues, and also issues of like cost, how long will it take you? How long do you have to wait when you get to a vaccination center? So all these do influence the uptake of vaccination, but not necessarily hesitancy. What we've seen, especially in the COVID era, of course, it's a disease that came with infodemic right from the start, is where do people get information? And this information we found actually comes from social media. In Africa, we have all the anti-vaxxer videos come from the US. In West Africa, where we have the Francophone countries, they come from France. Just one anti-vaxxer does a video and it goes viral, but you will rarely find the African-made anti-vaxxer videos. And this shows you that in Africa generally, even when people get on social media and write anything negative about vaccines, but at the end of the day, we'll get a high coverage. We'll get people getting out and having their people or their children or themselves vaccinated. Right now, hesitancy is an appropriate focus for us in terms of the volatility of attitudes. So in recent months, we've had many large market research companies that have been carrying out polls, and we've seen a number of those from Heidi that I will not go back into. And we've seen generally that the world, most countries around the world, have an increase in the number that would say, yes, I would accept to take the vaccine. These studies have been very minimal in Africa, and the information we have is usually from South Africa, which is basically not a usual African country. It's not a country that we can justify as an African setting. But we suspect that people will become less hesitant, even though we have people who still sound hesitant, as the programs get established, the vaccinations go on relatively smoothly, and then becomes normalized. At least we know in the African continent, we shall not get loads of vaccines at once. The vaccines will come in tranches, and by now we shall know then how to respond. And where hesitancy might exist, how shall we respond? Based on the data and evidence, experts have conceptualized the range of positions that people may be on the hesitancy continuum. So we have the activists and all the ones we normally call the anti-vaxxers. And these ones, all we want to do is minimize their impact. Then we have those who generally reject vaccination. They don't campaign, they don't say anything, they call themselves organic parents. They don't vaccinate. And with this group, we just want to maintain trust and keep open doors and give them as much information as we can. Then there are the hesitant group. These ones we want to understand and address their concerns and make sure that there is a good process to know, are they undecided or they're just delaying their vaccination. In Africa, it's very common that you have a vaccination campaign start and some parents will say, let's wait and see what will happen to other children before we can take our own children. So this group is usually clustered in a specific community, and with those ones, we also design activities to help them. And with those who are accepting vaccination, we know they can change their minds anytime. We want to maintain their acceptance and their good experience, and they can be advocates for us. And in terms of those with strong demand for vaccination, we want to maintain the expectations and provide good quality services, because even a rude health worker can turn around the thoughts of anybody who was a good advocate and had strong demand for vaccine. Then we have the advocates, those ones we support them with advocacy. Then I want to finish with an alliance. It's, in December 2020, WHO launched the Africa Infodemic Response Alliance, and this really was given birth to from what happened with the whole COVID pandemic. It comprises of 13 partners. We are working with several partners, including the Africa CDC. We have the UN. We have the International Federation of Red Cross. We have a number of them, UNICEF, and all those. So basically, we are there to map online discourse around the COVID-19 and the vaccines in the media and social media in the African region, and we want to work to counteract that misinformation, either through videos or articles or media engagement, or supporting journalists to be able to counter that. Otherwise, we hope that to achieve all this, our parliamentarians, our opinion leaders, our religious leaders, we know they all play a critical role in both advocacy and community engagement, and in being a positive voice and being a champion for vaccination, countering misinformation and all. We hope for the best. We are looking forward to our vaccines coming, and we hope that in the next few weeks, Africa too will start rolling out the COVID-19 vaccine. Thank you very much.
Okay, that was really terrific. Thanks so much. So we do have some questions in the Q&A box. I am going to take moderator's privilege for a moment and really pose a question to both of you. I am interested in hearing your thoughts, whether it's in regards to other vaccines or specifically COVID vaccine. What do you think are the strategies or strategy that has been most successful in the past in building vaccine confidence? That's the question for you, Heidi. And Phionah, what strategies or approaches have you seen that have really stimulated uptake and even have created demand? What has worked best? So perhaps Heidi, if you would respond first.
Sure. Let's see. Well, I think the most important thing, the first thing is to listen, because I think we've created, without realizing it, more antagonism by dismissing or saying, oh, don't be silly, or I mean, worse than that, calling people ignorant, or, whatever, or suggesting that they don't care about their children. Of course they care. I mean, I think that we have to change the language around these often tense discussions around misinformation. I think we need to understand it. We need to listen a lot of times, and I've certainly learned this in the front lines with some of the polio work, where we think it's a rumor that's stopping people, but actually the rumor was something that people said, oh, it's because of that rumor about sterilization or whatever. But when you actually sit down and talk to them, there's actually other things that are bothering them, and they didn't want to say that, but it was easier to say, oh, it's that rumor. And actually maybe they're uncomfortable. We saw in some situations they didn't want a man vaccinating their children, or they didn't want people coming from other places to take vaccines from, like from a city, or they wanted local people who they trusted. So it's very much about getting trusted engagement. I think, certainly I had a call before our seminar now, or our webinar now, with one of the bishops here about their church network and how they're getting a lot of requests from the church leaders, that they have a lot of very questioning parishioners. So I think that, and they want to help. So I think we need to partner with the people who are trusted in communities, and help make sure they have the right information, because they're being turned to. When people don't trust authority, they'll turn to people that they're more familiar with, who they feel comfortable with sharing their concerns with. And we need to find out who those trusted people are so that they have good information, because that's not their training, and they're not going to be, but they're the people that are the trusted ones.
Great. Okay, Phionah.
Yeah, thank you. So I think Heidi has mentioned, so we get among the people who, the sources of information we found that people use and rely on when it comes to vaccines is the media and social media. So we also need to move ahead of these times and do, for example, at WHO, both the regional offices and global level, we do these media briefings every week. All media globally comes and we give them the right information. Otherwise, if you don't do this, they will pick up any kind of information and use it. Then we have the other practical issues, like people saying we now have working mothers. In Africa, generally, it's mothers that are caregivers. We have working mothers. They have to work also an 8-to-5 job. Are we able to provide services during off-peak hours? Can we do early morning? Can we do late evening? Because vaccines in Africa, generally the vaccination services are offered during the day when we do not have, when the mothers are unable to come. Then we have the religious leaders and religious sects. These are people, and for a continent like Africa, we're a very religious continent. Much as we also have the opinion leaders and all that, but religion plays a major role. So when we do have messages that we have to pass across for vaccines, we need to learn how to integrate them with their religious messages and what people believe in. So you have your vaccine, you can say God protects those who protect themselves, who take care of themselves. So you have the vaccine, then you can continue with your prayers. But also when they see the trusted caregiver in church with them or in a mosque praying with them, it becomes a whole different thing than if they do not see you. But also most important is to emphasize, to change our messaging from vaccines are good for you and good for life, but to emphasize the safety and effectiveness of vaccines. And this should be able to increase our demand.
Super. So now I'm looking at the questions in the Q&A box, and we have some really terrific ones. We'll see if we can work through most of them. There was a question that had occurred to me as well, and that is the question about comparing measures of vaccine confidence, willingness to get vaccinated, for example. How do those measures compare with actual vaccine uptake in different areas? Perhaps, Heidi, you want to comment on that?
Yes. Well, when we've seen, and we have done a number of comparisons with uptake, more when it came to childhood vaccines, because we haven't had enough data in terms of uptake on COVID, at a population level yet, to be comparing. And also the COVID sentiments are changing by the month, sometimes by the week. They're up and down depending on people's perceived threat of the virus. So, but in general with vaccines, interestingly, even though safety is the biggest anxiety of the different domains of confidence, we see that confidence in the importance of vaccine is the strongest predictor of actual vaccine uptake, which when I think about it, it makes sense, because if you don't think a vaccine's important, it doesn't matter if you think they're safe or effective, because you don't go that far. But if you believe in the importance, that's going to be the lever for it. So yes, we do.
Are these surveys conducted as phone surveys, or are they face-to-face interviews? Just
It depends on the country. I mean, the first thing we do is do an assessment of, what is the most common and accessible mode. And sometimes even in a place like Nigeria, we'll have one part of it that is by phone, one part of it that may be online, and then, up in the north and in some of the areas we actually do house to house, well, when it's possible, interviews, and it's all local language.
okay, great. I think a question for Phionah. How is WHO planning to handle the idea that perhaps, some individuals in Africa will say, well, I've already had COVID, so I don't need this vaccine?
Yeah, we see that coming up all the time. And the serious surveys we are doing actually now show that we do have higher numbers of people that have had COVID than was reported. But WHO has also made it clear from the studies that we are doing that the vaccine, the immunity keeps waning over time, the natural immunity that we get from the COVID-19, the virus itself. But also, we have most of our countries now showing that we have several variants. We have the variant first discovered in the UK. We have having a number of countries in the African region with the variant first discovered in South Africa. So, and now the studies that we have from the scientists from South Africa are telling us that the immunity that was conferred by the original variants that we had is not helping with the new variant. So in short, we still need the vaccines to get protected, because even when I had COVID personally, it will not, that immunity, those antibodies are not working against the new variants. And yet we're having the new variants spread like a bushfire, and we are even discovering more variants. But again, definitely the natural immunity still does wane off, and that has been demonstrated. Over.
Right. So how is WHO tackling this particular communication task?
Like I mentioned, we are having these weekly webinars, weekly media. In the media, it's all of, because it's something that we keep talking about of, and most of the time we're having media briefings, this question will come up. We're having herd immunity, and hasn't everyone gotten it? Actually, Africa should not be the continent to say that, because Africa was basically the least affected continent when it came to COVID-19. We were affected economically and socially and in all other ways, and of course with our fragile health systems. But the number of people that did get the virus cannot really get us to what we are calling herd immunity. So the communication is going out. We are communicating and communicating. We have the global level communication and the Afro level communication, and journalists are out at it. If it's not yet out, then definitely we shall have to find other ways of pushing this information out.
A question for Heidi, asking about your views on political leadership regarding COVID in the UK specifically. Beyond the Prime Minister's approach, what are your views about public health mitigation measures there across the major political parties and among the leaders of the political parties? And what steps have impressed you most regarding the social mobilization that's taken place in the UK?
Well, I think the control measures have not been great. They got started a bit late, and I mean, just we shouldn't have had 120,000 people die. And I think some of that was because it was a bit of a bumpy start, and people were a bit confused. But that, I mean, some of that is perfectly understandable because everyone was trying to get a handle on things. I do, on the positive side, I do think that the logistics of getting the vaccine out quickly and so many people vaccinated has been really quite an achievement, and really, I think all the people have been involved, to their credit. And it's been happening in churches and mosques and gymnasiums, and that happened quite efficiently. The question though is who's getting. I mean, I always ask. We hear a lot of numbers, which are big numbers that have gotten vaccinated, but I always want to know, well, who's not getting vaccinated, because and that's the challenge right now, because as I understand it from the GP networks, that 2 to 3% of whites offered the vaccine said no thank you, but 20 to 30% of Black, Asian, and minority communities have said no thank you. So right now, and we kind of expected that because of what we know from vaccines in general and where there are more resistant communities, and probably should have gotten an earlier start in terms of engaging with those communities and listening. But at any rate, I think the numbers have put some pressure on that. And there are measures now to try to get more engaged with the lower vaccinating communities. And we're not even in the population level that's going to be the more resistant. I mean, it's still the highest age group.
There's a question about the impact of limited access to vaccines, and we can think about access to COVID-19 vaccines right now. And, you know, how does that affect the data that you're analyzing? But let me go first to Phionah and ask whether a sense of limited access to COVID-19 vaccines would serve to actually create demand, or would it in fact serve to basically stifle demand? Which way would it go? Sometimes we want things that we can't have right, as human beings, but sometimes we also say, oh, then forget it, it's not for me. What's your take on limited access, particularly in the African region?
Thanks, Jessica. This has worked both ways for us, because you know, in Africa, we are always saying Africa being used as guinea pigs. For the first time now, the vaccination started in the developed countries, and then we are coming next after we've seen lots of people get the vaccine in the US, in Europe, but also Black Africans out there getting the vaccine. So this has helped to calm us down and calm down the people and show, okay, actually, we can actually take these vaccines. But then we also have the issue of where there are many people who ask you, where can I get the vaccine? Where can I buy the vaccine? Then you tell them, myself, I'm the new vaccine introduction office. I work with WHO. I've not had access to the vaccine. And it's quite amazing. And I actually do not know where I'll get the vaccine. Because I am based in a different country. Am I counted in that country?
I don't either, by the way, Phionah.
You also haven't gotten the vaccine.
Really?
And I don't know when I'll be able to.
There you
exactly. Go. Yeah, so it plays two ways. At least the fact that it didn't begin here. The Ebola vaccine began here. The yellow fever is always here. The measles outbreaks have usually been in Africa. The polio vaccination, so all that has been in Africa. But this time around, the vaccines did not start in Africa, and that created some bit of confidence, and we expect to improve the demand. We've not seen the lack of access actually taking us the other way down, because populations have learned that we are doing our level best. The African Union is doing its level best. The COVAX facility is doing its level best to try and get these vaccines here. But that delay has bought us some time to actually create demand. Okay.
That's a good.
Okay. There's a question asking about what's the most successful way to work with government officials at any level to really, modify their level of confidence. I mean, Heidi, you spoke about listening, but I sort of want to say, and then what comes after listening, right? I mean, but it's really a question for both of you in terms of, specifically working with government officials?
Well, I mean, I think from the listening is how you inform your communication, because if you don't listen, you don't know what's really bothering people. And, you know, too often, the kind of strategies coming from public health authorities is what the health authorities think people should know, not necessarily what people's questions are. And you need both. I mean, I think it's important that public health authorities put out what is basic essential information for whatever the issue is. But at the same time, there needs to be a sense that people feel like their concerns are heard. So one, if you listen, you're already building trust because you're willing to listen. But two, that you start to integrate the answers to those concerns into the kind of outreach and communication strategies. And the more that happens and the more people, so it has a twofold thing of not only trust building because people feel like their voices might be heard, but two, that actually you're improving you're informing your communication strategy.
Okay. Phionah, how about you? Your experience of working with government officials at different levels. Any tips, really?
You know, with the COVID vaccine in particular, it has really been a difficult time, especially to get vaccines to the African continent. The fact that we were not manufacturing vaccines and were fully reliant on vaccines from out there, well, not that we normally manufacture vaccines, but the COVAX facility worked to communicate every step of the way to the government, so that the government officials are at the same level as the technocrats in international organizations, for example, or other people. So we had several webinars with heads of states, and it was really amazing to see like a president of a country, several presidents, because there would be heads of states and their technical officers, but the heads of state themselves asking questions and reassuring them that these vaccines are actually safe. This is how far we are. This is what we are going to do. We need you to sign an indemnity and liability agreement. This is what it will take. Please check with your legal department and all that. And then the legal officers come in. You find the Attorney General in the office in the country coming on in to support the Ministry of Health for some of these processes. So then when it comes to the Ministry of Health, here we have the technocrats. We also had different levels of webinars and trainings for them, and they were always showing up and asking questions and writing back to you. We gave them addresses to write to, and they really were interested because I'll give you an example. In Africa, we have in the African region for WHO 47 countries, and we have had 37 of these give us their national development plans. Please preview for us. What do you think? Do you think this is the right way to do it? This is our budget, these are budget gaps and all that. And they're really enthusiastic and waiting for the vaccine. So government officials do play an important role, and they've been there and they're willing to, they are the people who will have to bring in the vaccine anyway and give it and distribute it and vaccinate people. So it's been, for me, it's been an easy way to work with them, apart from the difficult governments who we are still talking to for now.
Right, super. Okay, well, I think we are now officially at the top of our hour. So we need to wrap up. I want to thank our two amazing speakers, Dr. Phionah Atuhebewe and Dr. Heidi Larson, for such terrific talks that really stimulate a great discussion on an extremely important and timely topic. We still have some additional questions in the chat box, and we will see if we can come up with at least responses to some of them when we send around the link to the recording. So thank you all very much. And we'll just check with Fatima if there's anything else we want to say here as we close.
No, thank you so much, Heidi and Phionah, for thought-provoking points made. I will just ask that you, if you can, answer some of the questions that are directed to you in the Q&A, just so that we have them on file for participants. But thanks everyone for joining us, and please stay tuned for some of our upcoming webinars in the next few weeks. Thank you so much, everyone, and have a great day.
Thanks. Bye-bye.
Thank you. Bye-bye.